Hello and welcome to Adult ADHD in the Community Medication Management and Monitoring webinar, delivered by SPK Healthcare and presented by Haley Allcock, Trainee Advanced Nurse Practitioner at Combined Healthcare NHS Trust. To see more of our online content, face-to-face conferences and free material, please do visit our website www.healthcare.co.uk. Thank you.
So welcome everybody. Thank you so much for signing up for this. Vanessa reached out to me as a nurse prescriber and asked me if there was anything new I was doing or anything I wanted to raise. And I mentioned that over the last couple of years, this has sort of taken off quite big within our trust, certainly anyway. And I'm assuming it's pretty similar across the UK. So it's become sort of a big topic. So today I'm going to try and get everything into the 40 minutes. If I'm going too fast or anything, please, pop something in the chat. I will try and talk slow because I do tend to. Just a little bit about me. I won't bore you for too long. So I qualified in 2005 as a mental health nurse. I have worked in all different areas of mental health, including neuropsychiatry, acute inpatient, and community mental health, which is where I am at the moment. I started my master's degree for advanced nurse practitioner in 2019, just before COVID hit. And I've just completed everything. So I'm just waiting for one more thing to come back to be marked, and it's all done, thankfully. Okay, so 4 years ago, I was asked to pick up the monitoring clinic for a small number of patients that were prescribed ADHD medication. So, Haley, can you pick up these 2 clinics a year just to do the mental health and physical health check that's required for the GP? Yeah, that's fine. Didn't know anything about ADHD. So I've sort of the last 4 years self-taught and fell in love with it. So it is my baby, if you like, across our trust. So we currently have upwards of 80 people. So I think initially it was about 28, something like that. It's climbing each week. We get lots of referrals still. So now I'm the lead across our community directorate in ensuring all the community teams are providing the best care for these group of patients as per NICE guidelines for adult ADHD. Okay, so I've popped this on. So ADHD is part of the neurodevelopmental disorders. So it's in there with dyslexia, dyspraxia, and Asperger's. There is crossover, there can be crossover in diagnoses. We'll talk about that a little bit later on about mental health, but it is within that group of neurodevelopmental disorders. So what is ADHD? Let me just move my picture because I can't see what I've wrote. It's one of the most common neurodevelopmental disorders within children. I am sure you have all maybe seen, heard over the years, stereotypical naughty kids. Children with ADHD have trouble paying attention, controlling impulsive behaviours, may act without thinking or be overly active, predominantly inattentive presentation and high presentation. So those are the 3 sort of elements of ADHD. A person can have 1, 2, or all of them, and obviously then that is going to be problematic for that child. Okay, so it's important to know that ASD, so autistic spectrum disorder, and ADHD themselves are not a mental health disorder. They're not a condition, and not every person with a neurodevelopmental disorder will have mental health difficulties. However, we do know that having a neurodevelopmental disorder means that young people are more vulnerable to developing mental health problems in the future. For example, they often find it more difficult to understand and manage their feelings and the feelings of others. They may muddle different emotions or find it hard to understand what is causing them to feel the way they feel. For example, struggling to work out what the trigger is for a particular feeling. Additionally, some struggle to communicate their thoughts and feelings to others, and this can cause high levels of anxiety. The person may instead communicate their feelings in a way that is not instantly understandable to others. For example, when they're highly stressed, highly aroused, they may become more fixated on routine, engage in repetitive behaviours, as opposed to becoming visibly distressed. This, alongside sensory sensitivity to their environment and social situations, often people with autistic spectrum disorders can quickly shift from being okay to being utterly overwhelmed with their emotions. There is some crossover with that with ADHD as well. Okay, so ADHD, onto this one on its own. Okay, so ADHD, attention deficit hyperactivity disorder, is a condition that affects people's behavior. People with ADHD can seem restless, may have trouble concentrating, may act on impulse. Symptoms of ADHD tend to be more noticed at an early age and may become more noticeable when a child's circumstances change, such as when they start school. It's not always recognised in childhood. However, symptoms are becoming more prevalent in adolescent or adulthood, mistaken for other disorders such as anxiety, depression, risk-taking behaviour, drug and alcohol use, a range of mental health symptoms, chronic low self-esteem, failed immunity, sleep problems, which is a very big one and very difficult to treat. More likely to develop comorbid sort of trauma, PTSD, anxiety, depression, and substance misuse. We go into that a little bit more detail further on. Okay, so most cases are diagnosed when children are under 12 years old. However, those children that are diagnosed under 12 years old tend to be the children that are showing the inattentive and the hyperactive symptoms of ADHD. So your classic can't settle, can't sit, can't do the work, doesn't do the homework, causing problems within the classroom, encouraging others, disrupting others, that kind of thing would go noticed at school. Increasingly, though, individuals are being diagnosed later in life as an adult. We have had 3 years ago within our trust a waiting list initiative because there was that many people coming through the GP asking for an assessment for adult ADHD. So that took place and that then flooded the community directorate within the trust with people being diagnosed within this waiting list initiative and then transfer of care to the adult community mental health team for the ongoing monitoring, prescribing, optimizing, etc. That's where our numbers increase come from. it has got even more recently, but further on in the presentation, we'll talk a little bit about why that might be. Okay. So the symptoms of ADHD, if you're diagnosed as a child, usually improve with age, but many adults diagnosed with the condition at a young age do continue to experience problems. I've got a mixed bag of people on my sort of caseload who have come through from children's services or who have been diagnosed as a child, treated, stop treatment, and then come back as an adult for more treatment, if that makes sense. Okay, so what causes ADHD? I get asked this a lot. It's not completely clear, but there are some research that has taken place. So they're unknown generally, but current research, it shows that genetics play an important role and genetic factors with ADHD. I have actually got both parents and their adult child on my caseload because their adult child has been diagnosed with ADHD. They've gone, actually, that sounds like how I am. They've gone for their assessment and they've also been diagnosed with ADHD. So I have seen that link. Okay, so in addition to that, the studies are ongoing, and other factors may include brain injury. I also work for a brain injury unit, and I see patients there that have had a brain injury, and since that brain injury have acquired ADHD. And I've got a certain person that can't remember if he had ADHD as a child due to the brain injury. So those are ongoing studies. There is possible exposure to environmental risks, lead during pregnancy or at a young age. So they're thinking premature delivery, low birth weight, alcohol and tobacco use. I do apologise. Someone's knocked at the door. Alcohol and tobacco use during pregnancy. The genes you inherit from your parents are a significant factor in developing the condition. I talked about siblings. However, the way ADHD inherited is likely to be more complex, and it's not thought to be related to a single gene. So that study is ongoing. Certain people are also believed to be more at risk from ADHD, as I've said, from being born prematurely or the 37th week of pregnancy. I have touched on this a little bit earlier on, so I'm not going to go over it lots. So the subtypes of ADHD do not change within children and adult. They are the same subtypes: inattentive, hyperactive, and combined. With adult ADHD, I see more of the inattentive struggles within their lives. Okay, so misdiagnosis in adult ADHD. Touched on this a little bit. Untreated ADHD can really affect people's lives for both them and those around them. Despite this, ADHD in adults is often misdiagnosed or diagnosed as a more general psychiatric disorder. So you'll see someone that's really anxious, low, until you go into more detail, it would appear on the surface that that would be their diagnosis. So therefore, ADHD can be missed. You previously considered to be a childhood disorder, improve with age, but now recognised that it does persist into adulthood in 50 to 66% of people, which is quite high, which then obviously has that impairment and that general effect on their lives. Okay, I have a little video that I found really useful and could relate to as a practitioner. I'm going to try and play it, so bear with me.
Most of the time when you think of somebody with ADHD, this is what you think of. But now I'd like for you to meet Sally. Sally is an incredibly creative person. She has a master's in fine arts from Boston University. She's the person that people at work come to if they need fresh ideas. Sally has ADHD. So Sally's driving down the road, and there's this constant conversation going on inside her head. She's thinking, why did I have to look at that last email? I thought it was going to take me 2 minutes to write a response, and 20 minutes later, the stupid thing still isn't written, and I'm late. And I would say I'm going to do better next time, but I say that every single day and nothing changes. So what's the deal? And then friends and family, people who love Sally, say things like, you forgot? How could you forget? I told you 10 times. Are you listening to me? Do we need to get your ears checked? Are you just not paying attention? Or, how could you go to the grocery store and all we needed was bread and milk and you come back with $150 worth of groceries and no bread or milk? How does that happen? So you can see this would be a hard place to have confidence, because Sally has her voice on the inside of her head telling her she's not doing well, and she has voices on the outside of her head confirming it. So this makes Sally anxious. As you can imagine, a lot of adults who have ADHD feel anxious. Actually, 75% of adults who have anxiety actually have ADHD as the cause of their anxiety. Whether they're anxious or not, they know something's not right. And they'll make monumental efforts to make it right, but it's still not right. And they're usually waiting for the other shoe to drop, for everybody else to figure out they're not as competent as they appear. But here's the thing, Sally's actually competent. So what's going on? What's going on with ADHD? At its core, ADHD is a deficiency of neurotransmitters, mainly dopamine and norepinephrine. You need dopamine to be interested in things like what your husband is telling you to get at the grocery store. And you need norepinephrine for executive functions like concept of time and prioritizing. Because you need to know how much time has passed, so you know whether you need to stop answering that email so you can get to your appointment. And you need to know that it's more important to get to the appointment on time than it is to finish that email today. And there are many, many other examples I can give. Now I'd like for you to meet Tom. Tom is a people person. He is a great friend. He can connect with just about anybody. Tom checks his mail about once a week. Usually when the door to the mailbox won't close all the way because there's so much mail in there. Tom has to force himself to go get the mail. And he brings it in and he sets it down on the table because the mail's not interesting. Unfortunately, he sets the mail down on last week's mail, and that's sitting on top of mail from the week before that. So the mail started out being uninteresting, but then it ended up being overwhelming. And at some point, Tom just swept all the mail into a box and stuck the box in a closet. And it doesn't matter that there were bills that needed to be paid because they're not interesting until the situation becomes overwhelming. And now the water gets turned off because Tom didn't pay his water bill. Now he's interested. And this doesn't just happen at home, it happens at work too. At home, if Tom is overwhelmed, he can just move right past it. But he doesn't have that luxury at work. So if you see Tom sitting in a meeting, he is just seething internally because he has so much that he has to do, and these people are just wasting his time in another boring meeting. And the problem, it's not just the mail. It's the mundane details of human existence that we all have to deal with, like going to the doctor or going to the dentist. And people with ADHD know they need to do them, but they're either mundane or they're overwhelming. And you can see that neither one of those situations will get the job done until the situation becomes so big that they have to address it. So these are people who are living their life in crisis all the time. And just think about the health implications of that, the risk of heart attack, the high blood pressure, the weight gain. And this doesn't just affect the person with ADHD, it affects everybody around them because they don't understand what's going on. But then neither does the person with ADHD. Nobody understands what's going on. So this is the corporate executive who has great ideas, but she's late getting her end-of-year reviews done. This is the stay-at-home mom who is frantically running around all day long, but when her husband comes home, the house is a mess and she hasn't even started dinner yet. This is the college professor who's a great teacher, but it takes him forever to grade his tests. And this is the husband who has to stay late at work because he can't get any work done until everybody leaves, because that's when he can focus. Now, here's where this gets interesting. Because most people with ADHD, including Tom and Sally, are perfectionists. What's up with that? It's all about the shame. Because they know what they need to do. They're clear-thinking adults, but they can't get it done. And they have a world of people who see that they're not getting things done. They don't understand. They're not aspiring to be that person. They're trying really hard not to be that person, and it's not working. In their minds, the only way to counter the shame of not getting something done and then hearing about it is to do it perfectly. So what's the solution? That's the best part of this conversation, because there is a solution. Medication helps tremendously because this is a chemical deficiency. Sally gets her ADHD treated, and now she can have creative thoughts without having that big swirl of ideas running around in her head. And she can look at an email and see if she has time to answer it or if she needs to save it for later. Now Sally can be on time for her appointment. And that frees up the perfectionist who was trying so hard to be on time before and was failing every time. Tom gets his ADHD treated. Now he can open up the bills and pay them. And he can sit down and read a book and remember what he read. At work, Tom can sit quietly, as any adult would, in a meeting, even though it's a really boring meeting, because he doesn't have to stimulate himself to be interested in it. Now the corporate executive gets her reviews done and she has more time for her great ideas. The stay-at-home mom can spend time with her kids, really being present with her kids, because she's not frantically running around all the time. The college professor can help the students who are struggling because he knows what their grades are. And the husband can come home on time and spend time with his family because he got his work done during work hours. So does everybody have this? I mean, don't we all feel stressed at times? Yes, of course, we all feel stressed. But for some people, this is life-altering. They can't move forward, and they live a life of hidden shame. In the 28 years I've been seeing patients, in my professional opinion, I think we're looking at 2 to 3 out of 10 people. And that's a lot of people who could be feeling a whole lot better. Thank you for your time.
Okay. I don't want to spend loads of time on these because I don't want to run out of time. But it is known that, most people with ADHD do not commit crimes. However, childhood ADHD has high rates of comorbidity with oppositional defiant disorders and conduct disorders, which is in turn associated with the development of a dissocial personality disorder in adults. Adults with untreated ADHD can often be bored, seeking the attention of others, and this combination can end up in poor judgment with criminal acts as a consequence. Okay. So there is evidence to show that treatment of ADHD in prison population may reduce the risk of future offending, but that's an ongoing thing. Okay. This is a big one because typically for me, it's the young men. So young guys, 20s, 30s that are coming to me, they tend to use substances. Now for them, the substances that your average person would take for that high actually calms them, and they're finding that calming feeling. And again, they're using cannabis a lot of the time to try and sleep. This has to be managed in a certain way. So we are, using urine drug screen before we prescribe any stimulant medication, and working with that person on an individual basis to reduce that substance misuse, to to none, is the aim. And there is, I have to say, for me, really some really good success of, getting them off the stimulants, the cocaine or the amphetamines, whatever they may take, and prescribing an amphetamine-based medication. They no longer need those substances. So that tends to be what happens with ADHD and substance misuse. Do have some females, but generally it's young men that are coming through. This is quite a passion of mine, I have to say. So I've popped it in, and I'll talk briefly about this because ADHD in girls and women is different, very different, and very often missed in childhood. They don't tend to have their hyperactive symptoms that your young boy would have. They tend to be more inattentive, and their behaviours appear completely different from boys and men with ADHD. So it's historically been massively underdiagnosed, and I've had lots of women coming through with a diagnosis. So clinicians look at that your original model of your classic naughty boy, and that's sort of what that clinical appearance says. So it's overlooked that for young girls and women. Girls demonstrate symptoms of inattention, sometimes overly sociable behaviour, forgetfulness, talkativeness, or difficulties with time management. And I can go on to the next one to say this is what we notice is different, and this is what I am explaining constantly to my young ladies or older ladies that come through with a new diagnosis. So why has this been missed? How have I got to 30 without a diagnosis? I thought I was going mad. I thought there was something wrong with me. So these are sort of the things that women and young girls sort of display clinically. They struggle with organization, they struggle with detail, they will be forgetful, daydreaming is a big one, so appearing spaced out. So that young girl at the back of the classroom who hasn't wrote anything on a page because she's in a world of her own, and masking. So typically at school and maybe at work, a female will hold in all of those racing thoughts and all of that, all of that anxiety that they're experiencing at school or at college or at work. And as soon as they get to their safe place, which tends to be home, it just explodes. So that then can appear as come across as anger, intolerance to other people, and upset, very emotional, very easily upset by others, very sensitive, those kind of symptoms. So this is just a little bit more about that. So they internalize their hyperactivity. I can use a little bit of an example. My daughter, I'm absolutely convinced she has ADHD. We have discussed it together lots and lots. She is almost 16, and every school report is my daughter doesn't pay attention to her work. She's constantly daydreaming. She has to be reminded. She never does her homework, but she's an intelligent young girl, and she gets very, very, very frustrated at school. And the best subject she can engage with is art because she's then expressing herself. She comes home from school and the house knows she's home. That's the best way I can put it, really. So this is sort of why I get really I want to champion women with ADHD because it has been so missed so much and misdiagnosed over the years. Okay, this treatment is exactly the same as men: stimulant and non-stimulant medication, or non-stimulant medication, which we'll come on to in a second. But we do consider the other things that go on with us females, hormones, coexisting other diagnoses such as anxiety, depression, trauma, alcohol and substance misuse consideration. So why is it important to have a standard operating procedure? And when I say that, I mean, how do we manage this in our sort of domain, whatever that might be? I can see there's a lot of different clinicians or non-clinicians here today. So it's why is it important to have standards for treatment for these people? Okay, so since 2015-16, it has doubled the percentage of people receiving ADHD medications. The cost has increased in 80% since 2015 and 16, and the number of patients identified has increased by 118%. That is huge. Where are these people sitting? Who's treating them? What is their treatment pathway? Okay. I've just talked a little bit about that. The biggest rise has been with young adults, with treatment increasing 5-fold. So this is from The Guardian. This was quite recently. This was March of this year. With you know, this is saying we're failing these people. We need to be doing more. And again, just a little graph to show the increase since 2015-16, and that is an upward trajectory that is going to be continue. NHS England believes the true figure may be higher than that. Okay. Why the sudden increase? So there's a few reasons why this has sort of exploded across the UK, and I believe in America as well. As I've done my research, it appears to be quite similar over there. So increased awareness and education, more adults are becoming more familiar with the symptoms and seeking help. The destigmatization of mental health issues encourage people to come forward and say, actually, something's not quite right, doctor. You know, can I get some help? The evolution of diagnostic criteria, so that, you know, some trusts use the DSM-5 or the ICD-11 is now, includes ADHD. Recognition of adult symptoms, so understanding that you're not always getting that hyperactivity that you associate with ADHD. It's more of the inattentive symptoms. Lifestyle changes and work challenges. People are really struggling with those, you know, elements of their life, and then may seek professional help, which then can align with ADHD. As we all know, it is all over TikTok, and the internet as sort of, you know, picked up this and ran with it. We have a lot out there at the moment about adult ADHD. Okay. And again, the cultural shift in attitude. We are more accepting of mental health. It's not as stigmatized as it has been historically. So treatment, we should always make sure we are including everything about that person. It's holistic. It's addressing everything, not just those certain symptoms. If this person is really struggling with their lifestyle and they desperately need some help, that is when we are then thinking, right, you need medication. Okay. So treatment for ADHD is classified stimulants and non-stimulants. I'll go into that a little bit more, but not too long. So they have an immediate action. So they work very quickly. They're in and out your system within 10 hours. So they can be titrated to an effective dose quite quickly. And these are first-line treatments. Methylphenidate is generally the first one we try. If that person takes methylphenidate at whatever starting dose, if they notice a difference, we can then titrate up. There is an Excel version, so we can start on the standard dose, notice an improvement, and then we can move on to the control release. A lot of people, as you can imagine, with ADHD forget to take the afternoon dose, so the longer one is usually the go-to for that reason. Sorry about the dog, someone's knocked on my door again. Again, lisdexamfetamine, more newer, I guess, than methylphenidate. Work still a stimulant. However, every person I have found is so different that this can work for someone wonderfully, and for another person it really just does not suit them. The side effects of poor sleep, anxiety, stomach problems, etc., etc. And the last one is atomoxetine, and this is a very different. It's a non-stimulant, so it's an SNRI, antidepressant, essentially. And we try this. Not many people use this, but we use this in certain circumstances. If the stimulants haven't worked, or if that person is at risk of misusing. And the only difference is this requires a baseline blood for liver function. Common side effects of most of all three, if you like, of the medications, mainly in the stimulants, is that you can increase your blood pressure and your heart rate, and hence why we look at this. Loss of appetite, low weight, again, trouble sleeping, headaches, stomach ache. It can affect the stomach. It can cause irritability or anxiety, and atomoxetine, being a antidepressant, has that risk of suicidal ideation. So what do we do therapeutically? So we've done the stimulants. What else do we need to do? That person's a whole person. We are then thinking about, okay, if this person has underlying anxiety, underlying trauma, what are we thinking to do then? So we then offering therapeutic interventions. So for example, in our trust, we have an agreement with the primary care that those that are being treated purely for ADHD, we can then refer those in for instance, CBT, which is brain training. So it's goal-orientated form and helps people to reframe the way they think. So this, alongside medication, can make the world of difference. Other pathways, we can go, so there's anxiety and depression pathways, CBT, antidepressants alongside, and trauma. Everywhere will have their own treatment for someone with trauma. I could go into that, but I'd be here till tomorrow. So why do we need to change? So there are lengthy wait lists for ADHD across the nation. In our trust, it is approximately 3 years for an assessment from referral. There's no formalised structure in a lot of places. There's high prescribing costs associated for prescribing for long periods of time. Staff working in isolation, not knowing what to do or how to treat people. There is variation of practices across teams across the nation, and sometimes poor communication between teams. ADHD formed up to 50% of children's and young persons' caseload. It's certainly in our trust, and as I've already discussed, increasing caseloads in the community. This is a very boring slide, so I won't stay on it for long. I completed an audit of my CMHT, shows the current costs and how this has increased over the last 4 years. As you can see, it's increased massively for those that we are providing prescriptions for. Shared care agreement is what we use between the patient and the GP. We are doing the monitoring. We are making sure that person is okay, stable, safe, and then the GP then is satisfied and is happy then to take over the regular prescribing. I don't know how this works in other trusts. This is what happens with us, and this is what's been agreed with our GP in the local area. So we're monitoring. I'm mindful of the time, so I'm just going to whiz through this little bit and we can talk about it afterwards if need be. We are monitoring basically height, weight, cardiovascular and other things such as tics. Oh gosh, where's that gone? Sexual dysfunction, and any other of the normal side effects that I've just mentioned. And we're doing this every 6 months for that person as a reassurance to the GP and to ensure that that person's safe. So where are we currently? We have high caseloads in psychiatry for young people and adults with ADHD. We lack a consistent approach across diagnoses. If anyone has seen a Panorama documentary, if not, I have popped it in the end, the link to this. Please watch it. It is an eye-opener. Effective shared care agreement. Uptake differs geographically across the nation, and ownership or lead for these people in adult services. Building a case for change. This is the last slide. So I did some research yesterday, and NHS England are launching a new ADHD task force. They have recognised that this group of people is building. With a broad range of sectors, including the NHS, education and justice, engaging with patients, service providers, integrated care boards, many more, publishing these findings later this year, so keep your eye out for those. NHS England have pledged to continue to work with stakeholders to develop a national ADHD data improvement plan, carry out more detailed work, understand the provider, the commissioning, and capture examples from local health systems who are trialling innovative ways across services of delivering ADHD treatment and monitoring, ensuring best practice is captured and shared across the system. That is exciting for me, so I will be keeping an eye on that. And that is me done. Thank you very much. Sorry, I've gone over a little bit, Vanessa.
No, that's okay. That was wonderful. Thank you so much. It was so interesting. I've got a whole host of questions here
Okay.
on the second screen, so we'll just get right into it. And I think it's safe to say that no one would ever consider robbing your house with your dog. He sounds ferocious.
He's a German Shepherd.
So you've proven safety right there. Right. So I've got some questions. So I've tried to couple them to save some time. We have got people talking about wait times for assessment and diagnosis. So someone's asked, how do we get an adult diagnosed? And what is your current waiting time for assessment and diagnosis?
Okay, so generally the pathway to be diagnosed is to go through a GP. So go to the GP. You also have the Right to Choose website. In our trust, certainly, because the Panorama documentary was so damning and eye-opening, and again, if you haven't seen it, please watch it, and you will understand why we as a trust do not accept private diagnoses of ADHD. They are not thorough enough. They're just not the competency is not there. It's just not. So we as a trust have just recently a assessment and treatment service. It's in its infancy. Therefore, our current wait list is 3 years from today, which is a hell of a lot. And the biggest thing I'm facing, and I think we are across the trust, is people are desperate. They're going and paying £1,000 to £2,000 for this assessment and coming back to their GP. Their GP is referring into community. We're saying no, we're not accepting this. They need an NHS diagnosis. That's the biggest problem we're experiencing. And it's so unfortunate and so despairing for those people. But if you haven't watched Panorama documentary, that's the reason why. So I hope that answers the question. I'm not about that's within our trust. I don't know how it works across trusts, and I don't know what's set up, if there is anything set up, if there are any consultant psychiatrists are currently the only people who are able to do the actual DIVA, which is the formal ADHD assessment. I don't know how that works across other trusts.
Yeah. So then, whilst we are thinking about the wait times, quite a few people have asked about CBT and the impact of CBT in the wait. So someone asked, any tips for patients on the waiting list, i.e. self-help?
Yeah.
And then another person's asked, can CBT and coaching help alone? And then a third person has asked, what treatment options are available for people who are not able to take ADHD medication?
Okay. So the self-help is out there. I have added lots of links to the end of this presentation. There is a specific ADHD. Let me just have a quick look what I can read that out, but please please go. And so there is I have added it on there, I think, but if not, I will add it on. Just Google, but make sure you're using a reputable site. There is the National ADHD website that has got so much on there, videos, it's got testaments, it's got self-help, it's got tips, it's got everything. Regarding CBT, yeah, absolutely. CBT focuses on processing thoughts and managing thoughts. I've got a lot of people that have undergone or are going through CBT that are diagnosed and treated for ADHD because it's helpful. The third one is, what was the third one? Sorry, Vanessa.
It was, what treatment options are available for people who are not able to take the ADHD medication?
There isn't. So treatment for ADHD treatment is medication. It's an imbalance in the brain. The medication rights that imbalance, therefore helps with those symptoms. Unfortunately, if you're not able to take any of the non-stimulant or stimulant ADHD medication, treatment would then fall to self-help. It would fall to maybe undergoing some CBT to try and manage those thoughts.
Yeah. So we have another question. Do you have, this is a key change, do you have much information about how dysbiosis can influence symptoms?
Of what can
I believe it's dysbiosis.
Dysbiosis. I'm ever so sorry. I don't know what dysbiosis is.
Okay, let me hop on Google and I'll
Okay.
Can you test the levels of dopamine in a person to inform medication options?
We don't generally, no. We not that I'm aware of. So I haven't come across it certainly within my pathway in treatment. It is trial and error with ADHD medication, titration, changing formulations, even changing brands, because some brands have different rate release ratios. So it's talking through that with the patient and seeing them very regularly to do that titration.
So our next question is, what's the best clinical conditions for patients with ADHD to be screened?
I don't quite understand that question.
No, neither do I, as I read it out. If the owner of that question, if you'd like to clarify, I'll be happy to read it again. So the next question is, what is your experience view of the impact of late diagnosis on adult ADHD with a specific interest in relationships? They're especially asking about the impact of the unmasking process.
Yeah. Okay. Big. That I like that question. That is extremely common and relevant to that adult that's been diagnosed. I'm finding this with a lot of women. Okay. So women that they do the masking, their relationships can be very difficult. It affects every element of their home life, their relationship with their partner, how they manage their children, how they go to work, if they can go to work. Quite common to swap job to job to job to job. It has a massive impact when it's undiagnosed. I have people come to me and say, my life's a mess. I can't do this, I can't do that, I can't do the other. They've been diagnosed, manage those that forgetfulness, that anxiety, that masking that they have to do when they're at work, which is really, really, think about how you manage that and do a job at the same time must be so difficult. So yeah, the lack of diagnosis in childhood, I tend to see more in women, and they can be very angry when they come to see me. Why has this not been picked up before? Then I'll explain why. And they'll say, this has affected my life. Some people then have a history of involvement with criminal justice or drug use or alcohol use. All of those things, they come and say, I've done all of these things throughout my life, and they get medication and they don't no longer really need to do those things. I hope that answers the question.
So Leanne asks, once an adult has been diagnosed and prescribed a stimulant medication, how should they be monitored? How regularly should they be seen, and who by?
Okay, so it needs to be a prescriber, and somebody that's got a bit of knowledge about ADHD. That's building, as we know, nationally. Initially, I will see them, I will prescribe. I will only do a 2-week prescription. I will get them back in 2 weeks. We will monitor symptoms. We will check if that dose needs to be increased. We will optimize the medication, whatever that might be. That could take a couple of months, maybe. It could be 4 weeks. Everybody is different. Once they are stable and happy with what they are taking and what dose they're taking, we then request a shared care agreement with the GP. We then have a specific ADHD monitoring clinic. They then will sit within that. They'll get 2 appointments a year, which generally are telephone. We're then reviewing them over the telephone, which can be done by a nurse practitioner, me, a prescriber, generally advanced nurse practitioner. We also have our GP VTS doctor that does some of those clinics as well.
Perfect. Miguel asks, how do you deal with aggression in ADHD without escalating the behaviour further?
Medication.
Celia asks, if already on a mental health medication like SSRI or any other, can you also be prescribed an ADHD medication?
Yes. Wonderful. There is very little interactions with the stimulant-based medications. So if you are already on an SSRI or an SNRI, atomoxetine is already an SNRI. So that would be a different conversation. But for the stimulant-based medications, there is very little interaction with most medications. I have got lots of patients that take antidepressants alongside their stimulant-based medication.
Wonderful. I'm really going to say we are getting a bit pressed for time and we've got lots of questions. I'm going to try and speed this up. So are you experiencing an increased number of GPs refusing a shared care agreement once patients have been stabilised? If so, how are you dealing with this?
Yes. So I don't know if this is national, but I believe it is. We are getting historically, we've never had a problem. Our GPs have always accepted shared care agreements. However, recently, and it's political, won't go into it, there has been a bit of pushback for more information or more detail, which I haven't had before. So we're currently then having to get people back in to get this information, physical health information, etc., to then for the GP to take over. If the GP point blank refuses, then we have to continue prescribing, which then is a cost to us.
Trudy asks, I'm interested in
Vanessa,
understanding the impact of right.
Right, you broke up there. Can you start again?
Of course.
Yes, you're back.
So it says, I'm interested in understanding the impact of right to choose upon your waiting times and the numbers coming back to CMHT, the medication review, especially in cases of comorbidities.
Okay. I spoke to our consultant yesterday about this because I have had a few people who are waiting for an assessment to say, you go on the Right to Choose website, it's supported by the NHS, etc., etc. Every trust will be different. That is their choice whether they accept private diagnosis is completely their choice. We as a trust don't, as I've explained. And yes, it is having an impact on those people that have been diagnosed through your ADHD 360, for example, something like that. And they've been started on medication that they are paying a hell of a lot of money for privately. They're wanting them to come back to the GP, quite rightly, to have their medication prescribed within the NHS. The GP is referring that person into a CMHT because that's the protocol. We are then saying no, it is having an impact. We don't have the answers. I feel heart sorry for these people. I really do. But that's within our trust. Everywhere else, I have no idea how you manage non-NHS diagnosis and whether you would accept that diagnosis and treat that person.
Perfect. Sarah Burton asks, how do I encourage my patients to engage with their care?
Oh, gosh, that's a difficult one, isn't it? If they don't engage, I mean, with ADHD, if they come and they don't engage, they will be discharged from us. That is how it works. You come to us with an ADHD diagnosis with a name to be treated. We have very strict SOP that states, if these people do not attend 2 consecutive monitoring appointments, they are automatically discharged. They tend to come back through straight away, but that's the SOP. I encourage people to engage because you're talking through them about the things that are going wrong for them and the symptoms they've got and how this is impacting massively on their and generally gentle encouragement, why, obviously concerned, I don't want taking amphetamine-based medication, what will happen, blah, 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 blah. But, I'll just see them over time and see what they think. And ultimately, if they don't want the medication, that's their choice. We can discharge them back to the GP. But then, generally, working with people or other things, a person with ADHD can have been through childhood trauma, which then, there is different pathways. We can direct those people to the different pathways we've got for those different diagnoses while still being able to treat the ADHD.
Yeah. I'm just going to do one more question, but Haley, I'm sure that you would be keen to share your email address with anyone that has a burning question unable to be answered today. It's been I'm so grateful for the wave of interest.
And me, I'm trying to champion it,
absolutely.
So yeah, thank you for the opportunity.
So the last question is from Jill Trotter. She asked, what percentage of those diagnosed with ADHD inattentive benefit from medication in your experience?
Ooh, very high percentage. Yeah, very high percentage. I don't see a lot of hyperactivity in adults. So if I do, it's generally a young male, and I love them. They're brilliant. I have to remove keys out of drawers. I have to make sure there's nothing they can tap, bang, twist, because it drives me insane. That I see that. However, the bulk of people that I treat experience the inattentive side of ADHD. The medication, I have had some people say it's changed my life, you've saved my life. It works on every aspect of ADHD. It really does. So it's not just for the hyperactivity. I have people that say I can actually finish projects now. I can finish painting one room without I can focus. I've got concentration. I can wait my turn in speaking. I'm not going to be interrupting people constantly, and all of those things that go on with ADHD. The medication works. It works. If you've got ADHD, it tends to work.
That's great. Okay, I'm going to be sneaky and get in another couple of questions. So Rachel asks, do you need psychiatrist care for ADHD and why? And then Joanne says, can CBT and coaching help alone without medication?
Okay, so the first one, again, I don't know nationally, but generally, they don't need to be under a psychiatrist. Okay, so they don't need to be seen once they've been diagnosed, once they're diagnosed and referred to a secondary service, they don't, unless something else is going on separately, purely ADHD, do not require a psychiatrist. However, they will sit under that caseload. So a medical caseload, my caseload. So the ADHD guys, generally, most of them sit under me in the trust as an advanced nurse practitioner, and I tend to be the person that oversees all of their care, whether that's ADHD medication alone, whether I'm directing them through the pathways we've got for comorbidities, whether that's referrals to other services, primary care, substance misuse services, all of those things would sit with me as an advanced nurse practitioner. What was the second one?
Joanne West said, can CBT coaching
yeah.
help alone?
It can. Again, I wouldn't see those people, so I don't know. So I'm sure there are people out there that manage their ADHD without medication and use CBT, because CBT is wonderful for having tools to manage those racing thoughts, those thought processes, etc., behaviors. I'm sure there are people out there that do that. For me, the people I see have both medication and talking therapies, if you like, or a different pathway to treat whatever they are struggling with.
Yeah, that's wonderful. Okay, and then just on a last question, I think it's a nice note to fall on. So someone's actually asked personally that they have ADHD and they often need support in their network, and they find themselves making excuses for masking. They're asking, is there any advice that you can share or resource that you can share to help people understand kind of the basics of the ADHD?
Okay, yes, there is. Well, what I give my patients quite a big booklet that helps them to know is before you send the slides out, Vanessa, let me check all of my links and let me make sure I've got all of the resources that I direct my patients to online, which are credible, informative, webinars, so much stuff out there. And a deeper understanding of adult ADHD, specifically coping mechanisms, what might help, how to get support, what support is out there regards to online support. There will be a lot. So let me make sure I've got every link attached to these slides so that everyone can have a look and get as much information as possible.
That's wonderful. Thank you so much, Haley. Sorry, we are now officially over time, 6 minutes past.
Fine. I know I've enjoyed it. Actually, I was really nervous at the start, but no, it's been lovely to share my passion. So thank you for the opportunity.
No, of course. Thanks so much for joining us today and all the prep that goes into it. You can see, I encourage you to have a look at our chat box. It is full of love and gratitude.
Oh, thank you. I will do. Thank you.
I'd just like to thank everyone on behalf of everyone in the chat box for your time today. It's been wonderful.
Yeah.